Trying to conceive and feeling overwhelmed and confused with unhelpful information and advice? This podcast is for you. Welcome to Don't Tell Me to Relax. I'm your host, Hannah Pern, a fertility acupuncturist and passionate advocate for better fertility education and support. Our aim is to empower you with information to support your fertility journey and provide a community for connection with people who get where you're at. If you'd like to join us or work with us in clinic in London or across the UK, all the information is in the show notes at the end.
AcuPips sponsors Don't Tell Me to Relax. If you're looking for a way to naturally balance your body, calm your mind and relieve anxiety, then AcuPips has the answer. AcuPips is the UK's original ear seed company, founded by traditional acupuncturist Zoe Young. Ear seeds are small seeds or metal balls attached to an adhesive and placed on pressure points on the ear in specific combinations, creating balance within the body. Discover more today at acupips.com and use code RELAX for 20% off site-wide. AcuPips. Modern healing, ancient practice.
Hi everyone, and welcome back to this week's episode of Don't Tell Me to Relax. I am joined today by lovely Rachel, who many of you will know. She is my friend, my colleague, my partner in crime when it comes to many, many things, including courses that we do for acupuncturists on working in the field of fertility. But Rachel has very kindly come on to talk to us today about recurrent miscarriage. Before we get into that, Rachel, do you want to introduce yourself and tell us a little bit about your background?
Yeah, absolutely. Absolutely. What crimes have we committed then?
I'm not saying.
Crimes to fertility acupuncture. Yeah, so hi everyone. So my name's Rachel, and Hannah did actually a very nice introduction. Thank you. So yeah, I am a fertility acupuncturist and I run the Fertility Suite in Surrey. We actually have a very similar setup to Hannah. So we offer many different therapies as well as acupuncture. We have reflexology, nutrition, functional medicine, and an independent pharmacist as well. And yeah, that's kind of born off the back of my own fertility journey. So those of you that do know me will know that I'm quite sort of public in saying that I had IVF to have my son. And during that third round, I had IVF, and I will never know whether that was the one thing that made the difference. Sorry, I had acupuncture rather, but I will never know whether that was the one thing that made the difference. But I do know that it made me feel great, and I felt amazing after my sessions, and it helped with lots of symptoms for other things. And I feel like it really prepped me going into that last successful cycle. So then fast forward, I retrained, and here I am. And I'm really passionate about what I do, just supporting couples to get pregnant and have a healthy pregnancy. And whether that's, unexplained infertility, recurrent loss, or unsuccessful IVF, like we cover all areas of fertility. And then we work just the last year, really, we've really started working online with couples, offering one-to-one fertility and miscarriage assessments, which has been really rewarding, actually. We've had lots of positive outcomes with that. But I'll talk more about that later. But yeah, that's me.
So, Rachel, can you start by telling us the sort of definition of recurrent miscarriage and how it differs from obviously miscarriage? So what,
Yeah.
because there's many different terms for it. So can you explain a little bit about it, please?
Yeah, so certainly recurrent miscarriage, the definition is more than 3 according to the NHS classification. However, in certain patients, I would say probably more than 2. In older patients, maybe more than 2 would be classed as recurrent. I think it's definitely a red flag to have 2 or more miscarriages. But if we're really classifying recurrent miscarriage, it is 3 or more miscarriages.
And what do you think about that? Because it seems to me, and it definitely seems to obviously the people that we work with and I've ever sat with in clinic, that 3 is 3 too many before you can start having any investigations. What do you think about that?
Yeah, I agree to some extent that no one should have to suffer a loss, more than 1 loss or more than 3 losses, right? It's like, how do you quantify a loss? Like, you can't. Like, it affects everybody so differently, and it can be so traumatic that I think it depends on the reasons behind it, essentially. So if you have 1 or 2 losses, that could be down to certain reasons. And I know we're going to come on and talk about reasons for miscarriage. But if you're having more than 3 miscarriages, that then signifies that there are more potential reasons behind why. In terms of when you should start investigating, I think if you've just had 1 miscarriage, you're quite within your rights to push for some testing or do your own investigations. We always talk about being your own advocate, don't we? And I think being your own advocate, whether that's for fertility or loss, is kind of key to getting the answers that you need. And if you start that as soon as possible, it might be that you don't get the answers after one loss. It might be there's not enough information there to form a full picture. Quite often with loss, it's too late to do some testing for that specific loss. It's often when we look back in couples that have had 4 or 5 losses, we can start to see patterns of what might happen. But even then, we can't say exactly what the cause of past losses were unless there's been some sort of karyotyping or a really clear reason why it happened. But yeah, I think the sooner you can start, the better, right? In investigating these things.
And tell us, what are the most common reasons for miscarriage? Because often people are told it's kind of chromosomal, it wasn't genetically viable. That's something that we hear a lot. Is that the most common reason?
That is a really common reason for miscarriage. It's not the most common reason, in my opinion, for recurrent miscarriage. Recurrent miscarriage, i.e., when someone's having 3 or more losses, the most common reason actually is immune dysfunction or immune dysregulation, which again we'll come to talk about. But there was actually some evidence published recently to show that sticky blood or thrombophilias actually have very minimal correlation to recurrent loss. We know that sperm DNA fragmentation can be an issue in recurrent loss. I don't know what the actual stats are in terms of what the most common is, but I would say immune issues and sperm DNA or male factor fertility issues are high up on the list for recurrent loss. A miscarriage itself, chromosomal abnormality. But unless you've got a gene that you're both passing down, it's rare to have recurrent loss with chromosomal abnormality.
Yeah.
That makes sense.
Yeah, absolutely. And so if you have had because it's 3 miscarriages, isn't it, before you get referred for testing? Although I see people recently being referred after 2. That seems to be something that I'm seeing more commonly. What are the tests that are kind of offered on the NHS? Can you say a little bit about what they are?
Yeah, absolutely. So the NHS, it will vary slightly depending on primary care trust to primary care trust, but often it will be a sticky blood or thrombophilia profile. So a panel of tests, blood tests to check on how your blood clots. And that involves what we call like acquired conditions. And then you will maybe have some tests for antibodies. So you might get your thyroid antibodies tests or your ANA antibodies, which can relate to autoimmune conditions like lupus. You may be offered hysteroscopy, which is a camera inserted into the uterus to have a look at the uterine environment, looking for things like abnormalities with the shape and structure of the uterus or adhesions or scar tissue, which can actually, again, be a common cause of miscarriage. Certainly if you've had surgical management, that can be a risk factor. But that's pretty much it. Like you're going to get offered maybe some structural, physical investigation and then maybe some bloods. There are some consultants that offer immunology testing on the NHS. You've got Professor Quimby, I think, does quite a lot of the immunological testing, but it's quite hard to get in if you're not within that primary care trust. I know Dr. Shahata does some NK cell testing on the NHS, but then often to get the full treatment, you'll need to go private. So it does vary a little bit. And I think this is one of the biggest problems with recurrent loss is accessing care. I've actually just recorded a podcast with the Worst Girl Gang Ever all about this topic about the differences between NHS care and private care for recurrent loss, because I think we're from a generation, right, where the NHS solved all our problems. The NHS fixed everything. Like we could put all our faith in the NHS and they were able to help us in many ways. Now we're in a position where the NHS is really focusing on urgent care only due to resources. And I think for a generation, it's hard to understand that the NHS can't really help you with recurrent loss or fertility, or they can only go so far. Yes, they can help maybe a certain subset of patients, but there is a large proportion of patients that won't access the care they need to get the answers they need, whether that's for fertility, women's health, or loss. And it's that gap is kind of widening, and I think clinics like ours are filling that gap, but that gap really exists, right? It's, you know, as well
Yeah.
as I do, like the care's not there, but it's hard to get that across to people that the NHS testing is very different to what we can get privately.
Yes. And that is the problem, isn't it? That we see lots of people in clinic who say, I've had lots of tests done through the NHS and everything has come back clear.
Yeah.
And so then people are like, and so people are often told to try again. So, and which is obviously, if you've suffered recurrent loss, a terrifying position to be in, because you feel like there must be something going on here, because this is not usual. This is not bad luck, as people say, or this is not genetics or one of those things. There is something else going on. So, what can you do in that situation if you've had recurrent loss, your NHS bloods have come back fine, you've had, physical investigations, they've come back fine? What are your next steps, or what are your next choices from that point?
I think the first thing is kind of getting over that hurdle and realizing that, okay, the NHS have told me everything in inverted commas is normal, and then realizing that they haven't checked everything, and that actually the things they've checked might be normal, but there are big limitations around what they've checked. And then doing your research right. Again, it's like advocating for yourself. So, listening to podcasts, reaching out on Facebook groups, any WhatsApp groups you're in, Instagram. There's so much information out there. And I think actually there's some really good information out there often, and understanding what your options are and what your testing options are. There are so many tests that we can do outside of the limitations of the NHS that relate to recurrent miscarriage. There is loads and loads of evidence for sperm DNA fragmentation and its links to first trimester miscarriage. There
Mm,
is a lot of evidence around the health of the vaginal microbiome and first trimester miscarriage.
mm,
There are certainly scenarios where I have had patients who have had very basic ultrasounds and things have been missed, and just getting a second opinion, right? A second
mm.
opinion can be really, really important.
Yeah.
Um, there are more in-depth immunology tests that, there's an evidence base for, that can be done outside of the NHS. So again, it's reaching out. There's lots of people out there that can help you. Certainly clinics like ours, I know you do as well. We offer one-to-one fertility and miscarriage assessments where we'll spend 90 minutes with you, and we'll go really in depth into your clinical picture and your clinical history, and really look at what might be the causative factors, because often there's signs and symptoms there of
Mm,
what's going on. If you
mm,
dig deep enough into someone's clinical history, there are signs and symptoms of what causative factors might be. It's just
mm.
that they've not been delved into enough, and the testing's not been run.
And why is it, do you think, that so much of this sits in the private sector, not the NHS sector? Do you think that's, there's two questions. Why does it sit in the private sector, and is that going to change?
It's cost, right? It's cost.
Yeah.
I think going back to what I was saying about where the NHS is at the moment, the NHS is in an urgent care only situation. Like, they don't have the funding to treat certainly women's health and fertility and loss. The funding's just not there. They're doing a good job with what they've got to some degree, but they haven't got a lot, right? So
Yeah.
that's why the gap exists. And then you've got loads of amazing companies that are often started and funded and invested in by people that have had their own fertility or loss journey or their own issues with women's health. You look at loads of companies, they're all started by people that have come off the back of their own experience because they recognize that gap is there.
Mm,
And they're the ones doing the research. They're the
mm,
ones, because some people have been through this, have amazing medical backgrounds, right, or amazing skills, and they're setting up these companies to support other people going through the same thing. But they've got the skills to be able to go and do the research, or they can
mm,
get the investors to do the research, or the people. That research is proving things that lots of people have known for a long time. And then you've got all these private sector companies now going, actually, this research exists, the evidence is there, so let's offer these services to people. You look at vaginal microbiome testing, to use one example. In Vivo pretty much started the ball rolling with that. You've now got Screen Me, you've now got Day, and I'm sure there's others. You look at the sperm DNA fragmentation testing, that used to be quite limited. You've now got companies like Ian's company, Test Him, just about to start DNA fragmentation. You've got loads of companies are now realizing that actually there's a need for this. The evidence base exists, so let's get it out there and offer it to people. But I think the NHS, interestingly, when I was speaking to Laura from the Worst Girl Gang on the podcast the other day, Laura works in the NHS, and she said there's like this 15-year lag on like the evidence comes out, and then it
Yeah.
takes time to get the funding and the processes in place to get something working on the NHS right.
Mm. But it's really difficult, isn't it, from a patient perspective? Because there is often that fear, isn't there, that if it's not regulated by the NHS, if it's not regulated by the nice guidelines, is it money making? Is it, industry approved? Is it kind of just a theory? Because that's what people often come into our clinics, don't they? They want to
Yeah.
ask us, what do you think? Like, let's take, for example, immunology. So all the NK cells, immunology testing that recently was really red lighted a lot by the HFEA. There was a lot of kind of negative information from the HFEA about that whole side of the industry. And in fact, I recently sat with someone who had inquired about it and was told that the immunology was Harley Street witchcraft. So that person who's feeling very vulnerable and very unclear is being told by one person, this is witchcraft and it's just made up medicine. And yet, there is another person saying, this is actually the answer. This could be the solution to your recurrent miscarriage. And as an individual going through that, how on earth do you decide who to trust and where to go?
You're in such a vulnerable position, aren't you? When you're struggling with
Yeah.
fertility and loss, and we see it day in, day out in the clinic. Yeah, I remember that feeling, like you're really vulnerable. You'll do anything. So yes, you do have to be really aware. There is some witchcraft BS out there, right? There's all sorts. We've seen it all before, haven't we? There's people come in with all sorts of stories. You're like, you did what? Like, you sat on a pillow that blew hot air up your vagina. What? Sorry? Like, there's all sorts of things you hear about. But I would encourage people to go and look at the studies themselves. So there, for immunology, for example, there's a really good website called the Reproductive Immunology Centre, and they have a patient section where they publish lots of the evidence and the papers in this area. There are clinics using immunology protocols that have really good success rates. The reason a lot of these things don't pass the nice guidelines is, I think, my opinion is that it's actually very hard to produce solid evidence in fertility and loss. Firstly, because it's hard to find patients that want to take part in studies for fertility and loss. It's also very hard to know that what's going on in one person is exactly the same in another person. Like, you could have two people that clinically look the same, and you're doing a study saying that they're the same patient subset. But actually, there's different things going on in each patient. So how do you know there's not other factors involved? I think it's a hard area of medicine to get solid evidence in. So there's always going to be conflicting evidence, or people that say, oh, that's woo woo. Like,
Mm.
you could, the microbiome, sperm DNA frag, the immunology side of things, like, you could say to some degree lots of things are witchcraft, but the evidence is there. Like, have a go and look at the studies. You've got great websites like Examine for male fertility, In Vivo and Screen Me for the vaginal microbiome, and the Reproductive Immunology Centre. And actually, Dr. Shahata's website's quite good. He's got quite a few evidence bits and bobs on there. But fertility is a really fast-moving area of medicine. We have to remember that. It's one of the fastest moving areas of medicine, and it's constantly changing. I think back to when I had IVF, like, PGTA testing wasn't really a thing. And if it was like you only did that if you knew there was a genetic issue going on. Now, PGTA testing's done as standard in lots of clinics, or offered as a standard kind of service. And it's just moving really quickly. So what might be witchcraft, at the moment, might be proven to be solid and not witchcraft in 3 years' time. Who would have said, like, 10 years ago, people banging on about the vaginal microbiome, like, that would have been witchcraft 10 years ago when there wasn't really the evidence around it.
Mm.
And I think when you're struggling to conceive, you will do anything. Like, I had something called IVIG that was in my third cycle, which is one of these controversial sort of immune drugs. I'd had 2 unsuccessful cycles, and my consultant tested me for NK cells. At the time, I didn't have a clue what it was. I just paid for this really expensive test. And he said, oh, this has come back. You need this medication. And I'm convinced that's what made the key difference to my cycle working.
Mm.
But at the time, like, looking back, I was really vulnerable. I didn't question it. Like, I think, "My God, I forked out all that money." Didn't
Mm,
question it. Like, I think if you're not sure, you've just gotta read the evidence and find the evidence and put yourself in a position where you're making an informed decision. 'Cause
mm,
you never know whether you're making the right decision with anything in life, right? You have to
yeah,
just inform yourself and educate yourself and then make a
yeah.
decision based around that.
So, can you tell us a little bit more about the NK testing and sort of how that impacts recurrent loss?
Yeah, so immunology, like as I've already said, is like a complex area. And my belief is that if you think you have immunology issues, you really need to see a consultant that specializes in that area. Because I have certainly seen a lot of patients come through the door who've kind of said to me, "Oh, I've been given steroids and told that will help." But actually, they've not had any testing
Yeah.
done. And that's when you see things may go not quite right or they don't have success. So the immune system can become dysregulated. And it's without being too complex because I don't want to lose people at this point. It basically we all have something called natural killer cells within our body. They're there to fight cancer. They're like anti-cancer fighting drugs. And in some people, these cells become overactive, and they will not allow a pregnancy to progress. So they will not. When these cells become overactive, your body doesn't recognize a pregnancy as self, and then your body attacks the embryo as a foreign body and causes a miscarriage. And that can happen at different points. So in people who have unexplained infertility, that overactiveness is so strong that they won't even have a positive pregnancy test. That implantation won't even start to happen. And in other people, it can happen later, which is where you start to see recurrent first trimester miscarriage. The immune system's just not letting the body allow a pregnancy to happen. And the treatment is often immune suppression. I think suppression is probably the wrong word because you have an idea that you're completely putting someone in a position where they're exposed to becoming really sick. All it's doing is actually very gently modulating the immune system to allow a pregnancy to occur. And it's very short term. It's sort of normally up to 12, 16 weeks of pregnancy. And then the body takes over and accepts that the pregnancy is happening. In
Mm,
recurrent miscarriage, there's lots of studies to show that this is a cause of recurrent miscarriage, and actually through process of elimination of other things like understanding that thrombophilias don't have uh, the same connection to miscarriage as we'd previously thought, that kind of moves immune factors further up the list of like common causes of recurrent loss. So
mm.
yeah, if you think you've got an immunology issue, then my advice would be to have the testing and the treatment plan that goes alongside that under the care of a reproductive immunologist, someone that really knows what they're doing.
Yeah, and we've actually got a podcast episode with Dr. Tom from the Lister, who is a specialist that we send lots of people to from our clinics. So that's a good podcast episode to listen out for because he explains it in more detail. And I think, and I don't know whether I'm right on this, but I think that the HFEA and their recent kind of change, because it wasn't only to like a grey, it was actually to a red around the immunology side of fertility work. I think it was because it's that modulation of the immune system and the vulnerability that can cause to the person who's taking the steroids. But also, I think it might be due to the fact that we were seeing lots of people in clinic who were being given steroids with no evidence that they needed them.
Exactly that. And that's the key, right? If you're going to
Yeah.
take immune modulating medication, first of all, you need to know whether you actually need it or not. Otherwise, that's not ethically right. But secondly, it's a very complex area. And for some people, steroids is not the right treatment. For other people, intralipids combined with steroids or intralipids alone or other medications like Humira that modulate cytokine activity might be better. And it's really, really important that if you want to have success, if you think you've got an immunology issue, if you want to have success, you need to have the right testing done, not just part of the testing, all of the testing, and then someone who knows what they're doing to put the
Mm,
treatment plan together. Because it's not, you shouldn't just be taking steroids willy nilly. Like that's not really how
mm.
this works. And actually, you're not really improving your chance of success a great deal unless you understand why. I mean, I'm assuming Dr. Tum recommends that people have the testing.
Yeah, absolutely. And I think that's what I had seen last year quite a lot in clinic is that, for example, if people had one embryo and so this is, you know, through IVF. And then it was kind of a sort of agreement that we might as well throw, it was basically like, we'll throw the kitchen sink at it.
Yeah.
So we will do everything that we know we can possibly do to give you the best possible chance for that embryo to be successful. So that includes blood thinners, steroids, progesterone injections, which, you know, I totally understand, because as a person sitting there, you're like, well, you could do all the tests for thousands of pounds, or you could just take this blanket protocol that would cover the bases anyway. So I think as a person sitting in clinic, I think lots of people made the decision, I'm going to do that anyway. But exactly like you say, without that kind of individualized understanding of why they were doing it. So I
Yeah.
think that is what the HFEA were kind of sort
Yeah.
of bringing out the new report about.
Yeah. And it's interesting, isn't it? Like, you think you're throwing the kitchen sink at it, but actually, just by taking steroids without the testing, you're not really throwing the kitchen sink at it. Would be having the testing done and then the treatment
Yeah,
protocol tailored to you. But yeah, I can
yeah,
see why. I mean, the HFEA are there for a reason, right? Like, they're there to protect patients. So I can totally see why
yeah,
some things are not given the green light, and in some cases, quite rightly so. But I think when you're a patient, like, I would have taken anything that was red lighted if it meant I had a chance, right? And it depends on your individual
yeah,
circumstances. I'm not suggesting that's right for everybody, but if you're having recurrent loss and, like, some of the really critical things are being ticked off the list and you're still having recurrent loss, then of course you're going to try something that might not have all
yeah,
the red lights. Sorry, you might not have all the green lights, but actually, if you look at statistics from clinics that are using certain things, they're getting good results. So of course you're going to try it. Like, it's I think we need the regulation. Of course, we need the regulation, but coming at it from a patient perspective, like, it's hard, isn't it? You're in a really tricky position.
yeah,
You're vulnerable,
yeah.
and you want to try these things.
Yeah. And I think it's that lack of conclusion. That's the thing. You know, again, it's a bit like microbiome. You know, some people are like, this is the way forward. This is a really important part that we've been missing. And other people are like, it's, you know, it's complete rubbish. Let's completely ignore it. And I hear different things from different clinics, different consultants, different gynecologists. And I always feel for the person sitting in front of me who's going, what should I do?
Yeah,
My response is, arm yourself with information
yeah,
and kind of manage and navigate your own journey,
yeah,
because there's so much differing opinion. Nobody has the actual answer, because
yeah,
they just have different opinions
yeah,
and different theories depending on their background, depending on their learning. So I think you have to arm yourself, research, get the information, look at your case history, go through it with somebody, and kind of think about what are the sensible things that you
yeah,
can do. Like, what are the signs, like for example, vaginal microbiome, if you've got a history of
yes,
thrush or
exactly.
BV, if you've got issues, if you get discomfort after sex, then these are clues that really could indicate there is a dysbiosis, and therefore it warrants further investigation. That's what I would say. But if you're completely fine and you have nothing, then I wouldn't be recommending it.
That's exactly what I was just about to say. You have to look at everybody on an individual case by case basis, because, yes, the vaginal microbiome test might be a waste of money for some people, but for other people, that could be the missing piece of the jigsaw puzzle, right? And
Yeah,
fertility is fraught with grey areas. Wouldn't it be great if every time someone was struggling with fertility or recurrent loss, like, we could go, oh yeah, it's that one thing that we've identified and we can fix that and it'll all be better. The reality is it's a bit of an overlap, it's a bit messy. There's normally a couple of things that need optimizing. Some of those things don't often have solid answers. You're like, well, it could be, it couldn't be. And I think it's more about optimizing and putting people in a position where their chance of success, whether that's fertility or recurrent loss, is as high as possible, and eliminating as
yeah,
many causative factors as you can. It's never going to be solid and wrapped up. And that is really hard to sit with as a patient, because you want solid answers. And there's a lot of grey area. And it's really hard
yeah.
mentally to manage that aspect.
Yeah. And I guess what we've talked about, I mean, I know we've referred to DNA, but let's just talk about that a little bit more, because often what we see happening is that recurrent loss obviously happens to the female, but obviously there are two people involved in that situation. And so the DNA fragmentation is a deeper investigation into the male side of things, isn't it?
Yeah, absolutely. So a basic sperm sample will give you information on the parameters of the sperm in terms of the sperm count, how it's swimming, the shape of the sperm, the pH, any signs of infection. But a sperm DNA fragmentation test is actually looking at a cellular level, at the DNA. It's literally looking at the DNA strands of the sperm and telling you how many percentage of those strands are broken, and therefore what the likely level of damage is to the sperm and how likely that is to be a contributory factor to struggling to conceive or to loss. And again, the evidence there is now to show that if someone gets pregnant with sperm that has high DNA fragmentation, that will be a contributory factor to the ongoing development of that embryo, and it has a higher chance of first trimester miscarriage. Embryo development, you're exactly right, is 50-50, and you need healthy eggs and
Mm.
healthy sperm for that embryo to develop properly. It's not enough to say, oh, well, the sperm fertilized the egg, so it's done its job. The rest is down to the female. That's just not the case. We know that damage to the sperm at a cellular level means the embryo will fail to develop properly at a later stage at some point in the first trimester.
Yeah. And it never fails to amaze me that recurrent miscarriage clinics often don't test sperm.
Dr. Shahata and Dr. Tum will both look at sperm DNA frag. I don't know any other sort of recurrent loss clinics, but I mean, I certainly see
No,
patients.
sorry. When I say I mean NHS clinics, it's not even a kind of consideration, the male side of things.
Yeah, it's crazy. I mean, probably like you, I've lost count of the amount of recurrent loss patients that come to me, sometimes with up to like 7 or 8 losses, where I'm saying, okay, what's been checked on the male side of things? Nothing. What you're telling
Yeah,
me, not even a basic sperm sample? Nothing. I mean, that is
yeah.
crazy. The World Health Organization are recommending sperm DNA fragmentation as part of a standard male fertility markup. So how we're at the point where couples are having 7 or 8 losses and no one has even batted an eyelid at the male is just bizarre. And certainly, if you speak to people like Claire Mooney at Fertility Solutions, they're banging their head against a brick wall with it. Like, it's
Mm,
nuts, right?
mm. Yeah. Thank you, Rachel. So if somebody listening to this wants to find out more about doing some of these tests, what would you say to them? Because that's the other thing, isn't it? It's like, where do you go? Like, how do you sort out a clinic or a person or a clinician to help you navigate this? What would you say to them?
This is the hardest bit, right? Finding the help is the hardest. It shouldn't
Yeah.
be. But like I said, there's loads of great companies that are popping up now doing these. So it depends how you want to approach it. So, for example, if you're already working with an acupuncturist or nutritionist or functional medicine practitioner, often they will already have the links and the contacts to put you in touch with these people. So, ask the question. If you are not sure, then Instagram, can actually be a great place to start. Just reaching out to other people that have already had the test done. Where did they get it? How did they go about it? Companies, certainly, I think like Day and Screen Me, you can. They offer like free consultations. So if you can self refer, and then they will include a free consultation to go over the results. In our clinic, we
That's
do one-to-one.
for the vaginal microbiome. Sorry.
Yes, for the vaginal microbiome, sorry, yeah. And then,
Yeah.
like, certainly at Fertility Solutions that do the DNA frag, Claire does consultations with people afterwards. We actually, like I think I mentioned it at the beginning, it's actually something that's been a bit of a game changer for us in the clinic this year. It's been so rewarding. We've started offering one-to-one fertility and miscarriage online assessments where we will take you on for 90 minutes, either individually or as a couple, and we will go through your entire case history, no matter what that looks like, no matter how complex, and we will pick it apart and we will look at all of your previous test results and explain to you what they mean and any markers that come up. We will screen you for anything else that we think might be a problem. So we're asking those questions you talked about. What's your vaginal microbiome health like? What is the male factor side of things like? We'll look at, screen you for immunology, and then we will give you a follow-up email with everything in writing. We'll go through your supplements, we'll talk about lifestyle, nutrition, whatever support you need, and then we'll follow that up in an email that gives you like an action plan. So it's like, this is what we recommend you get tested, this is where you go and how you do it, these are the other things we think you might need. We even go as far as helping people who are already in the process with consultants about what conversations to be having. Like, what
Mm.
questions do you need to be asking when you have that follow-up appointment? What do you need to be pushing for? Like, helping people to advocate for themselves. Like, honestly, Hannah, it's been so rewarding. We've had so many success stories from working online with people. If you told me I could help people get pregnant online without them being in my clinic, I'd have been like, well, that's a bit limited. It's been amazing, like just being able to give people that support. So yeah, it's been a game changer for us in the clinic this year and being able to help more people. The whole idea I set this clinic up was I wanted to help as many people as possible, and going online to help people has enabled us to do that.
Yeah.
Yeah, but it's hard
And
to find the info right. It's hard. I get it.
yeah. And it's exhausting. You know, you're already suffering a lot, and you know, having to fight for everything, investigate, research it, having someone to hold your hand or guide you through is invaluable.
Yeah,
And yeah, you know, you're right. We see it in clinic as well. It's
yeah.
really invaluable. The other thing that I just wanted to ask you to mention is where to go to support. So you mentioned the Worst Girl Gang earlier on. So can you tell us a little bit about them? Because I know they're a great organisation for people looking for support who have suffered miscarriage, baby loss. So can you tell us a little bit more about them?
Yeah, they're amazing. So the Worst Girl Gang was set up by Bex and Laura after their own experiences with loss. And I think Bex started a Facebook group or reached out on Facebook for support. And it's just grown over the last 5 years to something incredible. So they now have a network of probably about 50,000 women. They have an online platform called The Warriorship. It's a membership hub, but it's very reasonably priced. And they have such amazing resources in there. They cover all areas of loss. So whether that's termination for medical reasons, whether that's stillbirth, whether that's second trimester loss, like they cover everything. Like if you need support, there will be someone else out there within their community that has gone through what you've gone through. And they do lots of online like support groups. They have lots of activities, loads and loads of webinars in there from experts with just giving information about advice and testing, nutritionists. And yeah, it's amazing. So if you head over to their website, The Worst Girl Gang Ever, and then you can sign up on there. And I mean, even their Instagram page is amazing.
Great. And I will put all their details and all your details and links to the other podcasts that might be of interest that we've discussed. Thank you, Rachel, for your time. As always, it's lovely to see you.
Always lovely to see your lovely smiley face, Hannah. Thank you so much.
We hope you have found this helpful. If you'd like more on fertility education, please see our Teaching to Conceive free course linked at the end of the show. You'll also find the link to join our community. For more personalised fertility support, you can work with us one-to-one in clinic and online. You can book a discovery call to find out more.